Well, good afternoon. As we're recording this, it's just a week away from Thanksgiving. And I don't know, I just really look forward to the gravy on the stuffing and the turkey, just being able to mush all that together and be able to enjoy some delicious Thanksgiving food. And I have to say that one of the greatest pies I ever had was on Thanksgiving. My brother-in-law, Chris McGinley, made this pecan brownie, like cookie crust with like homemade hot fudge sauce and homemade whipped cream. That was the greatest dessert I ever had in my life. So it's something I really look forward to is Thanksgiving. And obviously just being grateful to God for the blessings that I have received in my family and in my vocation, and being able to meet people like Dr. Blaise, I'll introduce in a minute. So I hope everybody can just take a moment to just be able to list, like, what are the top 10 things you're most grateful for? And to really share those with the Lord. There's that gospel passage that we always read, especially at Thanksgiving, about the 10 lepers, and they go to Jesus to ask to be cured. And then they actually get cured, and only one returns to thank the Lord for that. And I wonder if 90% of the graces God's been doing in me that I don't thank him for. And so Thanksgiving is such a great time to relish and cherish the gift that God blesses us with every day with our life and with our faith. So let's just pray for that. And the Father, Son, Holy Spirit, amen. Holy Spirit, we ask you to just let us be grateful for the gift of Jesus Christ in our life, for the gift of our faith, for the gift of our family and all those who put up with us every day. Holy Spirit, just let us to have hearts of gratitude, and that be a deeper attitude of just how we see everything that comes towards us as being grateful. So we ask you for blessing upon this program and the gratitude we feel for our own lives. The Father and the Son and the Holy Spirit. Amen. 2 points before we jump in. Well, actually 1 point about 2 things, and that is about the culture of life versus the culture of death, and especially poised in the abortion debate, in seeing that there is an opportunity here for preborn babies to really win a victory, and especially those mothers who suffer through this awful challenge of whether or not they should have this baby or not, and what a gift it is, those mothers who choose life. So we pray for all those mothers, we pray for all those babies, that they will be able to come to term. And there's 2 court cases to really keep in mind. One is the Dobbs case, which is could have the potential, as it's in the Supreme Court now in the United States, to really turn the tide on Roe v. Wade. So we pray that there could be some victory here for moms and for preborn babies. And more locally here in Pennsylvania, a huge PA Supreme Court case that seems like it's going to go the wrong way. The Dobbs case seems like it's going to go the correct way. It could potentially go the right way there. In other words, for babies and moms. And the PA Supreme Court case is one in which it's going to put Pennsylvania potentially on the same rail place as New York. I don't think we ever want to be like New York in anything, but especially not in this case. And so it'll basically be taxpayer-funded abortions. It will read into the Pennsylvania Constitution that abortion is a right. And so if those are watching, at the PA Family website has a very good summary of what's going on there. It's pafamily.org, Protect Unborn Life. And so they do some great work there. So it's a good way to follow that and pray that both of these cases, the PA Supreme Court case and the Dobbs case, will rule in favor of a culture for life. Speaking of life and speaking of a great culture, I had the blessing of being at Dr. Blaise's house for dinner about a month or 2 ago. And it's just such a great experience. I think the oldest is maybe, like 12 or so, like 12, that. Yeah. And then there's like 6 or 7 underneath that age group. So you walk into a house like that, and it's game on. It's so much fun. So it reminded me a lot of my time growing up with my 7 brothers and sisters. And I got to do mass in his house and just seeing his family. And then we got to go around and bless his house. And his wife was expecting, I think she was like 2 or 3 weeks away from having a baby. So it's just great to have Dr. Blaise on board here. I call him my knight in shining armor because I've had the, sometimes as a priest, definitely a very difficult subject to hear, and brings tears to my eyes every time I talk to a couple that's struggling to have a child and infertility. And so it's just such a source of real hope to be able to refer people, especially women, to a doctor who actually just cares about women and not about, like, I don't know, trying to get a checkpoint and whatever and money. I don't know how it all works. But anyway, the bottom line is that over the last few years, getting to know Dr. Blaise and being able to refer women to him, can now count 15 babies that are now in this world because of the incredible faith, work, love, and the just desire for the truth that Dr. Blaise stands for. And I've always found it interesting ever since I knew him. I love the name Blaise because of Saint Blaise, and the strength and the dignity and just the greatness of the Saint Blaise. I think as a little kid at St. Bernard's, it was the first saint that I really had a devotion to, because I just loved getting the candles, like get put around your neck like this. And then one of the greatest places to ever go, just like a vacation thought, if anybody ever want to do this, go to Croatia. And where St. Blaise is called Dubrovnik. It's like the greatest little town ever. So it has a little moat around it. You're waiting for the alligators to come and the king to come out and draw in there. And then there's this beautiful church, and they have these special candles that they like wind up, and then you can, and his grave is right there, and you can just experience this saint who's actually patron saint of like throat and diseases and all that type of stuff. And so I don't think he was a doctor, but he definitely, cured somebody who had something go down his throat like fish. So it's interesting that there's connection between Dr. Blaise and Saint Blaise that I find to be fascinating. At any rate, to introduce him more formally, he's currently working at Trinity Hospital in Steubenville. He has been trained in naprotechnology. He did his residency at Sisters of Charity in Buffalo, and did his med school at George Washington. He is also, he graduated from Sewickley, grew up in the very borough in which we're filming this, which is Sewickley, PA. So to leave it to that, Dr. Blaise. Dr. Blaise, what is your favorite Thanksgiving food? Like for me, it's definitely, I just love the stuffing with the gravy and a little bit of like turkey all mixed in. Like I can't beat that bite. What is your favorite Thanksgiving?
It's hard to put it's hard to pick one, because I'm like you. I like to mix right in the center.
Yeah, that's key.
They all come together in the middle. You have your potatoes, you make the big, indentation for the gravy, and then you got the stuffing, and you got whatever else you have, a corn, yada yada, cranberry sauce, and then the turkey. Sometimes it all mixes right there in the middle, and just get a bite of everything. And that's a beautiful thing. And then there's that after Thanksgiving sandwich that you can make too. You get some Italian bread, and you kind of put it all in there, and it's fantastic. So anyway, it's hard for me to say just one thing. I love all the things. I love Thanksgiving. It's just great.
And what about dessert wise? Like for me, like I said, I described that awesome pie, but you can't reproduce that every year. So I just always go to the pumpkin pie. It's a good, safe thing for me to eat.
I love pumpkin pie. I'm a big pie guy, but there is a dessert that's been passed down through my family.
Oh,
yeah, from my grandmother. It's basically, it's sweet potatoes with brown sugar and some oats as the base. And then it's cranberries on top. Wow. And then it's marshmallows on top of that, and you bake it. It is unreal. It is so good. I mean, it goes fast.
What do you call
it's made. I don't even know what you'd call it. I don't even know.
Like sweet potato Alaska? It sounds a little bit like baked Alaska a little bit,
But it is absolutely phenomenal. And I love it whenever my mom or my wife now makes it, and it goes fast.
Is this a Grandma Milburn thing, or is this on the other side of the family?
This was my grandmother, on my dad's mom. She started making it, and then my mom took over the recipe, and then so now my wife makes it, and it's incredible. So that's probably my favorite thing about Thanksgiving, is getting to that.
Yeah.
It's kind of a dessert. You can say it's partial dessert, partial meal as well. It's got sweet potatoes. It's vegetables.
You said it at the beginning. It all blends together on Thanksgiving.
Whatever.
Yeah, it doesn't.
It's health. It's health.
Sure
Nutrition.
You're a doctor, so you should be okay with that.
Cranberries, vitamin C. There you go. It's good stuff.
A little bit. You just had a baby. If you wouldn't mind, I'd like to show a picture of the baby. There we are. So who's in the picture there?
Yeah, there's my wife, Sarah. We were high school sweethearts, actually, met at Sewickley Academy. And we're there in our delivery room at Trinity, and that's Bryce Charles, born October 8th.
So, October 8th, and he's doing well?
He's doing very well, growing well, nice and healthy. not the greatest sleeper right now, so we're working on that. But he's nursing great. He's growing, and we're just incredibly blessed.
So list the names if you could, and kind of the kids there. If you want to go through that, if you know them all, you can do it. If not, just do your best to get.
Sure, I might get hung up on one here or there.
That's okay.
Oftentimes during the day, I'll stop. Wait, what's your name?
Yeah, that's fine.
So I'll do that.
Fair.
And it'll come to me eventually. Coleman is the oldest. He's 12. Madeline is next. She is 9, soon to be 10. Her birthday is December 21st, so it's coming up. And then there is the twins, Aiden and Cullen. They're 7. And then 5-year-old Clayton. Then 3-year-old Mara. Just turned 2, Connor and Bryce. So I think that's all 8.
That's 8.
Is that 8? Okay.
We'll rewind, see if you missed one, but I think that counts for now. High school sweetheart Sarah. So you guys were at Swickley same year. What happened there?
Yeah, she's a year underneath me, so behind me. So I was a senior, she was a junior when we started dating. It's interesting. I mean, I was there for 2+ years and never spoke to her. I knew she played soccer. I was on the soccer team as well, so I saw her play soccer. She was a very good player, but we never had a conversation, nothing. And when we were in Spanish class my senior year, an AP Spanish class. I think it was AP Spanish. Yeah. And she was there too. And that was the first class we ever had together. And eventually I got the nerve to speak to her, and one thing just quickly led to another. And I was like, this is the one for me. I felt an immediate connection, immediate friendship. We connect on so many major things. Our faith being probably certainly the biggest thing, but, our love for sports, we're both athletes, was a nice connection as well. So it was natural from the beginning.
And she was like a real superstar soccer player. Did she go to the States, or did they?
Yeah, she won state championship.
Wow, that's
she
incredible.
Her senior year, she won state championship. It was the first AA team in Pennsylvania, women's AA team to win the state championship from the western part of the state.
Right.
That's what I meant. So yeah, she was a great player. She was all whitfield player. Yeah, she was very good. She went on to play at Carnegie Mellon initially, had some injuries, stopped playing, but yeah, she was very good.
When did you propose to her? Like, how did that go down?
I proposed to her. I was out of college. She was, I think, finishing up her senior year. So it was the first year I was out of college. So this is, I think it was 2008-ish. I'm trying to remember. Maybe the end of 2007. But anyway, I proposed to her at Mount Washington. I recreated our first date. Our first date was Signeri's Italian restaurant in Coriopolis. Very good restaurant, by the way. Anybody, if you want to.
Do you get like a percentage kickback on that?
I should.
You should.
So we went to Signeri's. That was our first date, and then we went to Mount Washington and just spent the night walking up there on the bluff overlooking the city, and you just can't beat that view. And I proposed to her up on Mount Washington. So that was
that's awesome.
Yeah. So
and you guys moved back from. You were living in Indiana for a while. Mm-hmm. Is that right? Fort Wayne.
Right. Yeah. So I did residency in Buffalo, as you mentioned, and then I did fellowship in Omaha at now the St. Paul VI Institute. It was the Pope Paul VI Institute before he was canonized. And then I got my first job out of training at Fertility and Midwifery Care Center in Fort Wayne, Indiana. I was there for 2 years. Very busy practice. Did a lot of surgery. Delivered a bunch of babies. It was very good. Started looking around a little bit at other options, and then I got this job at Trinity. One thing led to another, and been here for about a year now. So
talk a little about how you got interested in this aspect of the medical field that you're in, mm-hmm. and a little story of how you got to want to study this area.
Yeah, I've racked my brain for the moment where it hit me, and I can't think of exactly when it was, but there was a moment when I was watching EWTN one. I used to watch that all the time. With my wife, or even by myself. And they talked about the clinic out in Omaha, the Pope Paul VI Clinic, and Dr. Hildress and what he's done. And I never heard anything about it, and the type of medicine that they were practicing in naprotechnology. And as soon as I heard that it was like a diamond bullet between the eyes. I was like, oh my gosh, this might be it for me. But I know I hadn't yet even applied to medical school. So this was early. This was like college time-ish, I was still trying to figure out what I wanted to do with my life. But I heard that, and that just spoke to my heart so unbelievably, I was, oh my gosh, that never got out of my mind. So that was always working on me, in the back of my mind. But I will admit, when I first went into medical school in the first year, I thought maybe pediatrics is for me. I like kids. Maybe that would be it. And 15 minutes into shadowing a pediatrician the first day, I knew, nope, can't do this.
But you'll have 8 kids.
Right. It's easier when they're your own kids.
Okay.
It just wasn't for me. It takes a certain personality, and pediatricians are wonderful people. I'm not hating on pediatricians. It just, I knew that wasn't for me. So I kept an open mind with knowing about NAPRO technology, the fact that I heard about this all along, and thinking that maybe this is probably going to be it for me. But I went into my 3rd year rotations still with an open mind. And once I got to my OBGYN rotation, even though it was not great scenario necessarily in terms of being a little bit, I wouldn't say anti-life, but just being, for all the things that the church would be kind of against, a lot
so
of
even
contraception
in college and medical school, you started to feel this kind of tension between the truth that Jesus teaches through the church and where some medical fields are going the exact opposite. Like you could feel that tension already.
Oh yeah.
How so?
You can, I mean, it's a lot of times it's very subtle, it's under the surface, but other times it's quite in your face. My 2nd year of medical school, we had a human sexuality. Part of the course was human sexuality, and they showed a clip of pornography to start off the course, and bestiality was another clip that they showed, and as an example of this is what sex is becoming in our culture, or this is where it's going, where it's leading. And they brought on a bunch of people who were homosexual from a clinic nearby, talking about their experiences, a lot of transgendered people. So there was definitely an agenda that was being pushed for sure. And that was obviously very overt, but it was always kind of under the surface. It was always there. They never really pushed us to, verbally say, during our OB/GYN rotations that, say you're for this or you're for that. It was never like that. I never had to counsel patients on use of contraception or abortion or anything like that. But I mean, the residents did it. It was always right there. So it was very close, and then there was just a general feeling and culture. We had representatives from the AMA that came to speak to us. They were so blatantly left wing in every possible way. It was just really, so it just, all these little things just added up, and it just made an entire environment. That being said, there's a lot of like-minded people in my class that I found.
Oh, that's
so it was interesting. So
right.
I met a lot of people that felt the same way I did about these things. But you kind of had to search for them a little bit.
Mm-hmm.
So,
and so then you started to go into the women's healthcare even more from that point on, right?
Yeah, I'm sorry. So yeah, my 3rd year rotation, when I did OB/GYN rotation, and I really enjoyed it's very fast paced. There's such a breadth of things that you get to do. I mean, there's office procedures, there's time in the OR, there's major surgeries, minor surgeries, different types of surgery, whether it's open procedures or minimally invasive procedures, little incisions, laparoscopic procedures. There's deliveries, obviously, which are wonderful, and seeing patients in the office. So and then you treat all ages, basically, adolescent up to elderly. So it's an incredibly broad field. There's so many aspects to it, and there's so many different things about it. I really enjoyed that. And then certainly the life issues really spoke to me. If I felt like if I wasn't going to step up and provide this perspective and these things in this field, well, who am I expecting to do it for me? So I felt a little bit of I wouldn't say a call, but not like your call, but a little bit of that.
Yeah, there is
a little bit of that inside of me. Like I was pulled towards this.
Mm-hmm.
So.
And then some of your first experience would have been in Buffalo?
Yes.
So what was that like? Because you also worked with people who were from really tough backgrounds, both financially and culturally, right?
Yeah. So Buffalo, inner city Buffalo is just typical inner city situation. A lot of indigent folks that are not very healthy, a lot of drug use. Obviously, seeing a married patient was very
was rare.
Rare, yeah. I guess that would be the word. Yeah, very rare. So, but I love those people. I'll tell you right now, I love those people. And we gave them tremendous care. And I mean, they taught me medicine. They taught me general OB/GYN. They did. That's where I learned it, and that set me up for my fellowship. and I'm incredibly thankful for that place and that city. That place holds a special place in my heart. It really does. Buffalo gets a bad rap. It's actually a very nice town, very similar to Pittsburgh in many ways, actually.
Well, keeping with the food theme, they did invent buffalo wings, so that's quite
if you want pizza, hoagies, and wings,
can't beat it, right?
Nothing better than Buffalo. Buffalo is the place to be for that. So.
What's your favorite buffalo wing place up there?
Oh, the two famous places are Duff's and Anchor Bar. Those are the two famous ones. They're both excellent. But I'll tell you what, if you go find a hole-in-the-wall place,
just can't go wrong.
You might even get better wings. It's just a random hole-in-the-wall place, pizzeria that just does. They do that in the pit. It's really great. It's like I said, it's a place to be if you want that type of food.
Oh man, I love that type of food. So yeah, I'll be up there. I might just drive up tomorrow to do that.
No, it's good.
But when you were in Buffalo, when did it start to really awaken in your heart to get involved with NAPRO technology, to see other ways? Because the medical field as a whole has a culture with dealing with infertility or a lot of the female issues that are kind of one-sided. But you've decided to take a different approach, or you see that there's more than just the one approach. What was that typical approach that you found in Buffalo or wherever you went? And then how did you start branching out into NAPRO technology?
Well, in Buffalo, it was at a Catholic hospital, Sisters of Charity Hospital, the oldest hospital in Buffalo. And the residency program there was very Catholic friendly, actually. Mm-hmm. So there's only a few of those programs in the country. And so I looked for them, and I found one in Buffalo. Dr. Pivarunas is the residency director at the time. I don't know if he still is. In fact, I don't think he is. I think they're Dr. I can't remember his name. Okay. He was the assistant director at the time. He's taken over for him. But Dr. Stripmatter. But it was Catholic friendly. So we didn't do contraception. We didn't refer for abortions. We didn't do sterilizations. We didn't refer for IVF. I don't like to be defined by what I won't do, but we at least didn't do those things. Mm-hmm. And that was understood. And we didn't do any of that in our clinic either. And that was also understood with the patients. So that was nice to at least not have that pressure on you to kind of work around. And then we learned general OBGYN otherwise, with those parameters, basically. We're not doing these things, but we're doing everything else.
But that's such a radical thing. Like to have that framework is here's the gospel framework for how to truly allow women to be women. Mm-hmm. And you stayed in that, where the culture against that is not that.
No.
So what's the compare and contrast on that? Like what would be a typical hospital like?
It's very pro all those things. I mean, sterilizations are incredibly common.
Sterilizations.
Incredibly common. Yeah. Incredibly common. Oh yeah, tubal sterilization. Mm-hmm. IUDs, extremely common. I mean, very, very popular form of contraception out in the world, especially because women don't have to worry about taking a pill or anything. It's just in there for 5 years, sometimes 7 years, and they don't have to think about it. Meanwhile, it can be causing abortions and they don't even know it. It is abortifacient. So it's just very pervasive. All those things that I said that we don't do are very pervasive in a typical setting, in OBGYN or a typical hospital or residency program. Contraception is pushed. Abortion is definitely not just suggested, pushed. Sterilization is very, very common, very, very common. And then IVF is where you send them if they're having trouble getting pregnant, beyond just the very minimal intervention that a generalist can do, which is typically just give Clomid or something. Then you just refer them on to the REI physicians for IUI and IVF. So, yeah, it's a completely different approach to the human person, definitely. So I was very thankful for that setting, that I could train with a minimum of hassle and harassment, and then get a glimpse of what kind of a more authentic approach to the human person.
It's also a more holistic approach. In other words, you're respecting the cadence and the diagnosis of who a woman is before you're just starting to throw stuff
absolutely out there. So that undergirds the whole approach,
right?
Absolutely. The philosophy of how we view women guides the medicine, and that was definitely a part of it. So I was really thankful for that. But I thought about going into NAPRO technology when I was in residency, so that process started even probably in second year, because I'd already remember I'd seen Dr. Helger's video, or I knew about it beforehand. So while I didn't know exactly that I wanted to do that when I started, I think by second year I was pretty well set that I want to do this additional training so I can help women even more and offer this additional care.
So you throw out NAPRO technology as if everybody knows NAPRO technology. natural procreative technology. Officially, it's a new women's health science that monitors and maintains a woman's productive and gynecological health. It provides medical and surgical treatments that cooperates completely with the reproductive system. 30 years of science research and the study of normal and abnormal states so that the fertility cycles and the women's mysteries could be unraveled to be able to really work with them.
Yeah,
Before you define
well said.
NAPRO technology, one of the things that I like about what you said is that typically women will come with some type of a symptom, some type of a challenge, something that's hurting, a pain, or something that's not working, so to speak, normally. And the typical medical thing is a response without necessarily finding out a diagnosis before treatment. Is that right? Like, what's the way you want to work, and what would you say sometimes doesn't happen?
Yeah, I agree with that. So the typical approach is usually they jump to the pill. The pill is kind of a cure-all for everything in my field, unfortunately. But the pill is not a treatment. The pill is basically a huge Band-Aid, okay? And it treats the menstrual cycle as the problem. The menstrual cycle is not the problem. That's a normal physiologic
That's what happens with girls, right? Yeah, it's
the
like
way God made us.
Yes.
Every month,
Yes.
women are potentially able to conceive a child. And if they don't, they have a period. It's the way God made them. It is not the enemy. This is normal, okay? It's actually very healthy. The pill treats it as the enemy. It treats it as something that needs to be shut off. It doesn't need to be shut off, okay? So the way it's traditionally done in my field is they jump to that and they don't find out any cause at all. There's no explanation given for why a woman's having pain or heavy bleeding, whatever it may be, pain with intercourse. There's no investigation. Just the pill is used as kind of a cure-all. But with NAPRO technology, we're trying to find the underlying cause. We're trying to find the reasons. Okay, you're presenting with a symptom. What can we do to find out the reasons why you're experiencing this? And what can we do to treat that specifically? And we're not treating the menstrual cycle as something that needs to be suppressed or turned off here. We're working with the menstrual cycle. The menstrual cycle is revealing something to us, actually. It's like if you were numb completely in your body.
Yeah.
Well, you wouldn't know if you sprained your knee or you broke something, right? You were numb. So pain is a sign that something's wrong and something you need to find out what the injury is, right? So pain is actually good for us in a sense. Well, it's the same thing with the menstrual. The menstrual cycle reveals clues that tell us this could be what's wrong. It's up to us, the doctor, to do the proper investigation to find out the diagnosis for the patient. And there are diagnoses to find. And oftentimes, if you look for them, you do find the reason. But my field is very lazy, unfortunately, and we don't usually take that extra step or take any step.
Could you give an example of like a normal case of a woman coming to you and just then go through those 3 steps?
Okay. So the typical patient that I see a lot of reproductive age women, and usually they're coming to me with pelvic pain.
Okay.
That's a very common presenting complaint.
Right.
So I characterize the pain. I try to find out where is it located, how bad is it, where is it in location to your menstrual cycle,
right?
Because that'll distinguish whether it is gynecological or versus GI related, because the bowels are all down there as well, and the urinary tract for that matter.
Sure,
it's all in the same place, so you can't really tell with a female exactly which system is affected initially. But if it matches the menstrual cycle, then okay, it is gynecological. That's number one. And then where in the menstrual cycle? So is it with her period? Is it with the mid-cycle around ovulation time? Because it could be just ovulation. Is it after ovulation? So you're trying to find out where it's located. And then the question is, okay, what is the differential? What are you looking for that could cause it in that pain in that area or that timing of the cycle? With periods, could it be, she has fibroids, something wrong with the uterus organically? Does she have adenomyosis? Does she have endometrial polyps? Does she have endometriosis, which is a very common underdiagnosed condition? If it's mid-cycle, is she producing a lot of ovarian cysts where she's not ovulating? She's making ovarian cysts that don't rupture, that sometimes are hemorrhagic, they bleed into themselves. We can look for those with an ultrasound. The same thing with the period. We can look with an ultrasound. Is there anything wrong with the uterus? What do the ovaries look like? So, does she have a thyroid problem? So if she's got a lot of pain and cramping and heavy bleeding, does she have hypothyroidism or hyperthyroidism? So you do some investigation based on where the patient's symptoms are leading you. And then from there, then you can make a diagnosis, a targeted diagnosis as to what the problem is, and fix that. And if you fix that, then the presenting symptoms should go away. It's really quite simple. It's what they do in every other field of medicine. For some reason, in my field, they've forgotten how to do that. So
yeah, go figure. It just seems there's something we're missing here.
So I don't know if that answered your question.
It answered it perfectly. It totally did. And now go back to the original thing about naprotechnology. Tell us what that is. Break that down a little bit, because I think what you've just said obviously describes how naprotechnology works. But let's go to the kind of what is it?
Yeah, naprotechnology, natural procreative technology. That's a term that's been used to describe the approach to women's health that Dr. Hilgers basically has discovered or pioneered over the many decades of his work. He is an OBGYN out in Omaha, Nebraska. He started the Pope Paul VI Institute. Really great man. He initially started by just investigating the Billings ovulation method, and he tried to see if he could standardize the method. He ended up doing so, and that is called, the standardized form of that is called the Creighton model, which is a system of NFP. It's cervical mucus only method. So women chart their discharge pattern throughout the month, and cervical mucus is produced when a woman is fertile. So a woman can notice that right around when she ovulates, and she charts that so that she can observe her signs of fertility. And they can use that however they want. If they want to achieve pregnancy, they use the time of fertility to target intercourse. If they want to avoid pregnancy, then they just have to avoid the fertile time. But so he started out with those investigations, but from those investigations came more questions and more questions and more questions. And it just led him down this road where he started looking to all these different things that this charting was telling him, and hormone evaluations, different abnormal reasons for abnormal bleeding, things he was seeing on the chart, obviously what's causing pelvic pain. He did a lot of surgical investigation. So he found reasons for infertility and pelvic pain, endometriosis being the main one. And then he started pioneering ways to treat these diseases, specifically the surgical diseases like endometriosis. And so that was a big focus of my time in Omaha, was the surgical training. And I do a lot of laparoscopic surgery, specifically robotic surgery, which is a way to do laparoscopic surgery. This is minimally invasive through little incisions. Basically some CO2 gas is instilled in the abdomen, kind of blowing it up. And then through these little incisions, ports are placed, and then instruments go through those ports to do the surgery.
Is that called the Da Vinci laser?
The Da Vinci, there's the robot.
Oh, robot.
The name of the robot, yeah. So,
and how has that been important, robotics, with this technology? And
oh my gosh, it's absolutely critical. It's absolutely critical. But these surgeries used to be done through laparotomy, big incisions.
Oh, okay, right.
And patients would be in the hospital 3-4 days, a lot of pain.
Right.
And the visualization is tougher because you can't when your surgeon's standing there, you can't get really close. You can't put your head into the operative field. So that's poor form, put it that way.
That would be bad form.
So you could have loops on where it help magnify what you're seeing, but it's difficult. You're standing there for 6 hours doing the surgery. You can just imagine. And so the visualization isn't great. The post-op recovery isn't great. So the robot it takes all those problems away. They go home the same day through little incisions, 3D optics with the camera. You can get really close to the tissue. There's 6 degrees of motion, so it's like my hands are in the pelvis. I'm sitting 15 feet away at a console, looking through at a screen, but I'm controlling the robot. And the robot has full wrist action. The tremor is taken away. We all have a tremor in our hands. The robot takes that away. It's just a phenomenal way of doing surgery, especially endometriosis surgery, where you have to be very careful, very delicate with how you treat the tissues, specifically when people are wanting fertility, because you have to preserve good tissue, not just remove the diseased tissue.
So endometriosis, that's very common, right?
Extremely.
What is it?
It's basically cells that look like the cells that are on the inside of the uterus, the endometrium. That's just the lining of the cavity. That's where the baby implants.
Correct.
And that's what's shed each month in menses. So those cells get outside the uterus and they implant either on the exterior surface of the uterus, the fallopian tubes, the ovaries, the rectum, behind the bladder, or the appendix, all over the place, typically in the pelvis, although it can even be up in the diaphragm. So it can be many places in the cavity. But basically those cells implant. Some women can't clear them away. We don't know why. I think there might be an immune deficiency there, but and they're hormonally active. So they're stimulated from the hormones of your menstrual cycle. It's like you're menstruating in all these little different spots. Jeez. And they're very inflammatory.
Cause a lot of pain.
Cause a lot of pain. It causes increased nerve pain fiber growth in the pelvis. So it causes a very inflammatory environment where it makes conception very difficult. and causes a lot of pain. So they're usually presenting with those things: pain with intercourse, pain with periods, and infertility, or at least subfertility. Some women can get pregnant, but they have trouble with miscarriage, so they can have recurrent loss as well, which is a sign of it. So this is a big focus of NAPRO technology, is the surgical aspect, specifically how to treat endometriosis properly. Once again, we're treating the underlying cause of the problem.
Right.
And oftentimes when it comes to infertility specifically, it's endometriosis.
So there is treatment for endometriosis.
Absolutely.
And what would that typical treatment look like? You're saying like with this robotics to be able to...
So endometriosis is a surgical disease only. There
Okay.
is no medical treatment for it.
Okay.
It does not exist. Okay. So a lot of doctors will place patients on contraceptives. They do not treat the disease. They cover over the problem, or they cover over the symptom. They take away some of the pain sometimes, not always. Sometimes they take away the pain. So, but that the disease remains. It's the presence of the disease in the pelvis that is the problem. So you have to get the disease out, or destroy it. So it has to
Would
be
that be
surgically...
like if you had like a rat problem in your house and you just drywalled it rather than actually exterminating the rats? Is that kind of...
it's
just block it, just like...
Well, that's what the pill is, basically. It's like, if you had a roach problem, you're just going to plug the holes in your wall.
Yeah.
So you don't have to see the roaches anymore. Meanwhile, they're festering in the walls. I mean, it's kind of how the pill works in a sense. And that's how it works for this disease too. The problem is the presence of the disease in the pelvis, and you have to treat the disease. There is no pill, by the way, of any other medicine that treats this disease. You can't get rid of it unless you cut it out or destroy it. So it is a surgical disease. It requires surgery to diagnose it and to treat it. It is what it is. So,
and have you had success with that? Like,
yeah, a lot of success. Almost always the patients feel a lot better after the surgery. Fertility is not guaranteed, but the chances go way, way up.
Sure.
For the patients. So, but invariably they feel better. Almost, I would say almost every patient feels a lot better after the surgery.
So part of the challenges that you see would be like infertility, menstrual cramps, ovarian cysts, things like that, right? Are some of the most common issues that you're seeing as people are coming in, women are coming?
Bleeding, a lot of bleeding problems. A lot of women come in with bleeding problems, whether it's either abnormal bleeding or just heavy menstrual bleeding. That too. So all those types of things. Yeah.
And when you look at where you are now and a little bit of some of the experience you've gotten, are you more and more convinced that this seems to be something that can be so helpful and really ground changing for women?
Absolutely. I mean, I don't think I haven't run into a better way of doing things. I mean, this is, in my opinion, the way of doing the way that it should be done in my field. I think there is a philosophical underpinning to it that I think some of my colleagues don't necessarily ascribe to, I guess. But nonetheless, I mean, it's just it's a far better way of doing it. It's better medicine when you think about it, just from a medical standpoint only. In medicine, we want to get a diagnosis first, and then we treat the diagnosis. So we're diagnosticians as doctors, basically, any field. And that's your job as a doctor, is to get a diagnosis. So that's what this allows you to do.
Yeah.
This approach allows you to do that, to find out an underlying cause of the problem. Why wouldn't we want to do that? I think the word needs to be spread a little bit more. Certainly some hearts need to change, but it's just a better way of doing medicine, certainly.
Totally. Yeah, I agree. So a typical way for somebody to be able to find you, or to be able to have treatment, or just be able to get a diagnosis with you, one of the things you've told me is that, well, encourage them first to start charting. Would that be right?
Yep.
A little quick video, if we could put it up there, from a Dr. Marguerite Duane, and she talks a little bit about this. So if we could just listen to that for a second, then let's jump into it.
Ovulation is a sign of health. I was a 29-year-old woman passionate about women's health, and I had never heard any of these terms. Women can learn to chart their cycles so they can identify that period of fertility when they're able to get pregnant or not. Women are actually not fertile most of the time, and there are specific signs that they can learn to observe, and this can help them identify when they're fertile and when they're not, and then they can modify their behavior accordingly. It's natural, and there are no side effects. Hormonal birth control does not treat underlying disease. It may suppress the symptoms, but it doesn't oftentimes get at the underlying root cause. You should teach girls from the moment they go through puberty to learn to chart their cycle.
So you hear that? Would you agree with what Dr. Duane was saying there
Yeah,
about
100%.
really encouraging girls to chart?
I wish every young girl would learn this. I think it would set them off on the right path to getting proper treatment sooner. I hear a lot of women that come in to see me that have been really led down the wrong road and have been on contraception for years or have not had treatment for years, and I end up treating them. And you know, if they would have come to me sooner, they would have recognized the problems, and charting helps you do that. We could have spared them a lot of heartache and got them the right treatment sooner. So yeah, absolutely.
So if somebody's never heard about charting, what does that entail in general, and how would you teach somebody to do this?
There's many different forms of NFP out there, okay?
Okay.
Looking at different aspects of a woman's body to tell when she's fertile, when she's not, okay? So there's a symptothermal method that looks at her basal body temperature. So she takes her temperature each morning. When her temperature rises, that's a sign that she is ovulated, because the thermogenic effect of progesterone causes your body temperature to rise. So they're charting that. Obviously, create and model is a cervical mucus only method. So cervical mucus is produced during the time of fertility, like I mentioned. So the woman's charting that. Billings method came before Creighton, so it does the same thing. The Marquette method uses LH test strips. So luteinizing hormone is a hormone coming from the pituitary gland. It surges before ovulation happens. Ovulation happens 12 to 24 hours after that surge. So a woman is basically urinating on these test strips and finding when this LH surge is happening, so she can really target that time of ovulation. So there's different systems of NFP and different people that teach them. Couple to couple, like the symptothermal method. Obviously, Creighton model has its own system. Billings has a system, and so the different people out there in the world teach these different methods, and it's usually a one-on-one type of setting. Maybe initially it would be like an introductory session with a large group of people, and then eventually it's got to be on more of a personal one-on-one level, so that the client really understands day to day what they're supposed to do and how they're properly supposed to do it. Otherwise, if they're not doing it accurately, they're not able to properly identify the different aspects of their menstrual cycle, and they're not able to use the method. So
right. So for you, when you first hear of a woman saying, I've got these issues, you'll encourage them first to start charting, because typically that'll give you a way to start down a path of really getting to the diagnosis.
Yeah.
And so to start charting from the beginning of a woman's period is a good thing to do. And when she's first moving into high school and teenage years, that's the time to learn that, right?
I think so. Absolutely. Yeah. As a woman's starting to mature, I think that's a perfect time to learn that.
Yeah.
And it's a tool that they can use for their entire reproductive life.
Yeah.
To help manage their gynecologic health.
So. And just a quick advertisement for Modern Fertility Care. It's a website that's available there. I'm the chaplain to this, and there's some great doctors in the local area, nurses and experts who would help any of the girls. We're offering classes throughout the parish here in our grouping, and throughout Western PA and anywhere really. There's all kinds of information on there for different doctors, different experts to be able to help, especially young girls, be able to take that first step of charting, right?
Absolutely.
Then from there, if they've done that, then what's the best way for people to reach out and get a hold of you? How can people be in touch with you if they have some issues and want to receive help from you?
Yeah, I'm an employee at Trinity Health in Steubenville, Ohio. So they can call my clinic to set up an appointment.
And we're posting the phone number at 740-264-8600.
There you go. So they can call the clinic and schedule an appointment with me. And it's usually about 1 month, I think, to see me, but something like that. So it's not the wait time isn't terrible,
right,
compared to some others. And I always I'm trying to pare that down as little as possible so people can get in sooner. But yeah, that's probably the best way of doing it, I would say, just to call the clinic. Yeah.
Right. Yeah. So. And I hope that encourages anybody who will listen or have a chance to watch this, that there are ways to diagnose what's going on and get treatment that actually could be something that's helpful and relieving to some of the major issues that are out there.
Yeah.
Why do you think this point of view isn't as common for women's health today? Like what you're describing seems to be so medically sound. Like before you treat something, you should have a diagnosis.
Yeah, I don't.
I mean, I know in general it's a general question, but like, what's your
Yeah.
sense?
It's I think that there's a whole philosophy undergirding all of this. I mean, there has to be a difference in life philosophy in a sense. Obviously, our philosophy is much different than a secular philosophy. So I think that is unfortunately guiding a lot of what they do. And but this has been going on for decades. I mean, this has been festering for a very, very long time.
True.
But I think once the pill came on the scene in the 60s, I think that's when things started to kind of go downhill at that point. Once you separate procreation from the normal act of intercourse, I think that's I think one thing can lead to another at that point, and I think we're seeing the effects of that on a daily basis.
So that's just a good
certainly
point.
into my field.
There's no doubt that our culture has really generated a need, quote unquote, for contraception. For those who do not want to get pregnant, how does fertility awareness work? Is it effective? Is it not?
It's highly effective. It's highly effective. I mean, high 90% effective. I know the Creighton model, you can be up to 99.5% effective if you use it properly. So it's extremely effective. There is no 100% effective method. So I think vasectomy comes as close as you get. It's not even for the woman, but so there is no 100% effective method. And I mean, learning your fertility, NFP, Creighton method, other methods as well, extremely effective. Yes, certainly. But it requires continence. It requires abstinence.
Yeah,
it requires self-control.
Yeah.
And I don't know if some people don't want to do that. Others do. I guess that's a personal decision. Some people just want to take a pill or have a device in them. But if you want to do something that is perfectly healthy for yourself, teaches you about yourself, just requires a little bit of self-control, and is highly effective, NFP is for you, certainly.
Yeah.
And certainly moral as well.
And then talk about the effectiveness of just the fertility care that you offer. As you know, I was looking at a chart the other day that basically, if you compare NAPRO technology's effectiveness compared to IVF for things like diagnosing endometriosis, there's up to 75% effectiveness for the possibility of having a baby if you use NAPRO technology. Oh, thanks. They're going to put that up there on the screen. Appreciate that. But if IVF, it's 21% effectiveness. So 75% up to 75% versus 21%. PCOS, it's up to 80% effectiveness for NAPRO technology, where in vitro fertilization would be maybe around 25%. And then tubal occlusion would be around 40% almost. And in vitro fertilization would be 27%. So how do you see that? Like, what is the effectiveness as opposed to maybe some of the other ways in which people get pregnant today?
Yeah, it's much more effective. I mean, you just quoted some of the effectiveness of the ARTs, in vitro being the kind of the last one that couples go to. IUI usually has gone to first. Effectiveness of that is maybe 10%, maybe single digits.
Right.
And then IVF, even with a really successful clinic, you're looking at 30%. And then with a NAPRO approach, you're looking at up to 70, 80% sometimes. And you get a diagnosis. You find out what's wrong. I mean, that's the whole point. We're finding out what's wrong, and then we're treating the problem at its source. So it's not only much more effective, but you find out what's actually been ailing you all of these years. With the other methods, they don't care what your diagnosis is a lot of times. The number one thing that I see in my clinic is unexplained infertility. When people are coming for fertility, unexplained infertility, which is not a diagnosis, I would argue. Infertility is a symptom of a problem.
Correct.
Unexplained infertility, we don't know the reason for your symptom, basically, is what they're saying. And the reason why is because they haven't done enough investigation. And I think with the IVF and IUI, unfortunately, I don't think they care, because they can work around whatever it is. At least they believe they can. And with a technical process where you're creating children in a laboratory petri dish. It's a shame, it turns human reproduction into a manufacturing process. Or IUI, it's what we do to farm animals. So in any case, it's a completely different approach. It's far more effective, and you find out what's wrong with you. It just makes sense on every level. But it's unfortunately needs to grow in popularity, certainly.
Yeah, and I guess my heart goes to all those who struggle with any of these pains, issues, suffering, and just pray that through the research and through the the way in which you treat women, that there could be another option for women to feel that. And I imagine women who have gone down different roads and maybe hear this, it could be extremely triggering. Could be really hard to hear our discussion.
Sure.
But I would just pray that the truth about them and the truth about every woman is that, God saved the best till last. We just have to be honest with that. And in terms of creating women, it's what a treasure and gift. And I hope that our medical field can treasure our dear women as much as God does, and to recognize that when you step into the medical field, that you have a gift of being able to help care for and heal different challenges is just such a grace. And I've, since I've blessed with 5 sisters and a mom and then a grandma, I mean, just my family's just been so blessed with incredible women. It's just hard for me to be able to sit back and think that we're just going to let the current regime just kind of continue down this process of bulldozing the greatest gift that we probably have in humanity, which is a woman's fertility. I mean, gosh, they're co-creators. Just to be able to let them feel free that their fertility is not their enemy, but it's actually what truly is unleashing such a superpower. It's like, stop doing that to our women. Like, they deserve a chance to actually be who they were created to be, rather than being treated as some like enemy within.
Right. Yeah. There doesn't seem to be any thought towards the fact that we're human beings in my field, which is different than just a regular animal out there in the world. There's a greater dignity here. We're made in the image and likeness of God.
Correct.
And that isn't really, I don't think that underlying thought is not, it's either ignored or it's not even a part of how we view women in our field, because a lot of times, if they have endometriosis, then they're just going to go to IVF then, not even going to try surgery. Even if they do diagnose it, we're just going to go to IVF. Well, a lot of women don't want IVF for moral reasons.
Correct.
I mean, there's many reasons, cost being a big one as well.
Right.
It's tens of thousands of dollars, but the moral side of things is real. And to not give that any thought whatsoever, you're leaving out that whole part of a human person when you're considering them and what the best thing for them is. And that those thoughts aren't even brought into the picture a lot of times.
So like you bring up
so
a
it's a
point
shame.
there, just even financially, what would be the comparison between what you're doing and what a typical IVF procedure would be?
It depends where you are in the country, but
Okay.
IVF can be tens of thousands of dollars.
Okay.
They usually, obviously, they do payment plans. Sometimes they even offer you financing.
Wow.
Talking about a conflict of interest, right?
Yeah.
At very high interest rates, by the way, credit card like interest rates.
My goodness.
So tens of thousands of dollars, and sometimes that'll include certain numbers of cycles. Every place is different. It depends where you go and what state. New York City would be more than if you went to Iowa, probably.
Sure.
Et cetera. But in terms of what I do, I'll be honest, I don't know all the costs of what I do. That's one of the problems with medicine these days. It's third-party payments, so we don't know the cost of everything we do, but it's covered by insurance, whereas IVF is not. IVF is cash only. What I do when I do surgery or I'm seeing patients in the office, that's covered by insurance. So deductible would be the big out of pocket cost, and that's different for everybody. But let's just say it's thousands upon thousands less.
Mm-hmm. And then you'd mentioned before that sometimes to do different treatments, it takes a surgery that could take a little bit longer than the treatment that maybe others could offer, and you're willing to go the extra mile to do that. What's the difference in terms of how that goes? Because you just get paid, so to speak, for one type of moment, where if it takes longer, maybe it won't always work out. How does that work?
Yeah, unfortunately, with the way that we're reimbursed in medicine, we're reimbursed through CPT codes. I don't remember exactly what CPT stands for, but some procedural terminology. I don't
Sounds
know
like some code of some sort.
Anyway,
Yeah,
it's
okay,
codes,
whatever it is.
and everything you do in medicine has a code to it.
Okay.
And you're only paid based on the code, whatever the insurance contract is that says you're getting paid this much for this code. That's what you get. It doesn't matter whether you take 20 minutes on it or 3 hours on it. You're getting paid the same amount for that code. So it leads to it leads to a disincentive to do good work. It leads to just volume rather than quality, because you're not paid for quality or time. You're paid for volume. So it's a moral hazard is kind of built into the system, unfortunately. And doctors are susceptible, just like any other field is, to these types of things. So endometriosis surgery, even if it's done very poorly. It's done very shoddily, very quickly, usually just cautery. Electrical energy is used to just burn these lesions, which is the worst way of treating the disease, and causes a lot of damage to adjacent tissues as well. So it can lead to a lot of scar tissue formation. And really, it's just trying to go in, do it real fast, and get out, basically. Whereas the surgery that we've been trained to do at the Institute in Omaha, we use a CO2 laser. So it's a different whole approach to doing the surgery, where we're trying to dissect out the disease entirely to excise it. And then not only that, we try to repair the peritoneum, which is kind of like the skin inside of you. It's the peritoneal cavity. It allows all your organs to slide against each other nicely. That's the peritoneum. We repair the peritoneum. Whatever we remove, we try to repair that so you don't get scar tissue.
Right.
So it's not just taking out disease; it's repairing the pelvis as well,
Mm-hmm.
kind of reconstructing it. And so that's always with a mind towards fertility.
Correct.
And how this patient is going to heal after surgery as well, not just removing disease. So it's a completely different way of doing surgery, and it does take more time. It just does. And
isn't it worth it? I mean, we're talking.
It's worth it. It's worth it
Oh
when
my
when you
gosh.
see the change in the quality of life of the patient. It's worth it when
Yes.
they give you that email saying, "Thank you so much. I'm pregnant. Here's a after the birth they show the picture of the baby."
Oh,
And it's
you
always
can't
worth
beat
it. But is it worth it monetarily? Well,
Oh my gosh.
not yet. But it
Well, that's why I'm so grateful for you. People think I have some special thing, but all I do is send them to you. And now there's 15 little babies out there that have come through your medical treatments and just helping. And so I'm so appreciative of that. I just really encourage anybody to just grab onto our website, Modern Fertility Care, or give a call over to Trinity Hospital to do that, and to really encourage as much as possible to just that basic charting of and understanding the beauty and the dignity of what it means to be a woman, and that fertility, to be able to unleash that power is what just drives me so much, because I just see the greatness of women being able to be poured forth, rather than saying, oh, you're the enemy within yourself. And I can just imagine how hard that is to live like that. And so hopefully we can help women be free.
There doesn't exist anything for the men, right? I mean,
Right.
there's a pill for women. You got to shut off your fertility, but us men, we produce hundreds of millions of sperm a day.
Well, they started
that.
Yeah, this brings up a thing that was interesting. I read once an article where they started first this whole entire thing of contraception for men, and they tested it in Africa. Why Africa? I won't get into that issue, but that was, I think, in the late 60s, early 70s. And they started really realize that what this was doing was shriveling the reproductive organ of men. So they said, well, we don't want to do this on men. Let's go to the women. And so now here we are years later.
Makes you wonder.
Yeah, it does make you wonder who's really doing the slave stuff anyway. So a couple questions. This comes from Courtney Starr. She says, for vegetarians, vegans who eat soy-based products on a regular basis, how does this impact our hormones, NFP charting, or fertility, if at all? Do you know of any research being done in that field at all?
I don't. Certainly diet it plays a role in fertility. How much of a role, we don't know. There's a lot of anecdotal situations that I can point to in my practice and in my life that I've heard, but we're just learning about that, the link between diet and fertility. I usually put my patients on a keto diet or an anti-inflammatory diet, and that does have definite effects. How much, I just don't know. But in terms of soy, no, I don't specifically know how that would.
So she also asks, and why do you think in the U.S. there's higher rates of reproductive issues such as PCOS and endometriosis compared with first world countries? Is there anything that can be done to combat acquiring these kinds of reproductive issues for ourselves and or our children?
There is no way to prevent PCOS and endometriosis that we're aware of.
Okay.
But certainly obesity is a big problem in the United States, more than other first world countries.
Sure.
Obesity definitely augments a lot of the problems, the other problems that a woman has, PCOS being the one that definitely comes to mind with that. So yeah, that's a real issue. And then honestly, I mean, we don't look for these things very much even in this country, but I would say we probably look for them more than in many other countries, although I don't have evidence for that necessarily. But I would think that if you're not looking for these problems, you're not going to find them.
Right.
So yeah, we have more of it here. Well, we're identifying more of it. There's a lot more that we need to identify that we're not. but maybe we're looking for it a little bit more than they are. Maybe they actually have it too, but they're not looking so much for them. So,
Right.
if you don't look, you won't find.
It's true.
Seeking, you will find. Right?
Yeah. Well, before we wrap it up, I just wanted to wish everybody a blessed Thanksgiving. If you're hearing this before that, that's why I'm saying that. And our next program is going to be December 2nd. So we'll pause for Thanksgiving, and I'm going to be having my good buddy, Father Mike Roach, come on. We're going to talk about liturgy, especially the nuances from Pope Francis on the Latin liturgy and how to continue to preserve the language of our mother, and just talking about some of the great gifts of what the Catholic liturgy is for our community. And so he's somebody who has just a great love for liturgy, and also talk about some of the things going on with our current past work with our parish. So I'm looking forward to that after Thanksgiving. Dr. Blaise, thank you for coming on. Is there anything else that, after discussing this, that you would hope to share with women or anybody who's struggling with some of these issues we've talked about before we sign off today? Anything else you'd like to add, or some encouragement that you'd want to give?
I would just say that if you're struggling with these things and you haven't gotten an answer yet, there are answers to be found. And if you see someone like myself, there's more of us out there around the country. We can do investigations, we can do testing, we can do surgery, we can do things to get you the relief that you need. We can find answers for you when so many times you've been told, oh, it's just bad luck, or there is no answer. We can actually try to find out some reasons first and then treat them at their source. And so that there is hope. There's hope is what I want you to know. If you're looking for that, it does exist. And come see me, come see other NAPRO folks around the country. The fertilitycare.org is another website. So hope does exist. So
thanks, Doc. And I can't think of a better way to finish this by entrusting all of these discussions to Our Lady of Guadalupe. She's that beautiful image of Mary that's actually with child. And just know how close Mary wants to be to all of those who are struggling with these or trying to find solutions. So we just end by saying, Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of our death. Amen. Our Lady of Guadalupe, pray for us.